Today we're going to talk about bone health drugs. We'll cover the different classes, how each drug works, its benefits, its potential risks, but most importantly, we're going to walk through how each of these makes sense when I think that they could be a logical addition to a bone health program when viewed through the lens of Healthspan. Because as you know, I say often that I think the drugs are widely overused, but that there's a time and a place for each one. So let's get into this.
Sorry to interrupt this video, but you've heard me talk about Healthspan. You've probably heard me talk about healthy aging. And one of the things that we don't talk about enough are some of the tools that are more in the Healthspan space and not so much in the bone health space. One of those is resveratrol. And I'm bringing it up today because it can really play a role in both bone health and in cellular health and healthy aging. From a bone health perspective, it works like a SERM, a selective estrogen receptor modifier. It actually can push on estrogen receptors like estrogen, but not quite as strong. It also helps to reduce oxidative stress, and both of those things we know are good for bone health. So that's why I like 4Well's resveratrol complex. It's a high-potency antioxidant blend that's designed for everyday wellness. So think of it like this: steady energy, heart support, stronger cellular production, and even healthier-looking skin. So here's what's inside. Resveratrol is obviously the headliner. So this, again, is an antioxidant. It protects your cells and your bones from daily wear and tear. CoQ10 is in here, and that powers up your mitochondria, especially if you happen to be on a statin drug for cholesterol. Your mitochondria are like your cell's batteries, so this really helps your heart, and it helps from an energy perspective with muscles throughout your body. Now, vitamin C and E work together in a tag team mode. So C actually helps recycle E, so your antioxidant defense lasts longer from a vitamin perspective. And then there's quercetin. So quercetin adds another layer of antioxidant coverage. When you put all of this together, one serving gives you 1,800 milligrams of a thoughtfully stacked blend to support healthy blood flow, cellular protection, probably bone health, and everyday vitality. So the reason why I'm currently using this product is that it has real-world ingredients that have great research behind them and are complementary, and they're all packed into one product. So supplements are never one size fits all, and that's why you don't see me recommend one product for everybody. But if your interests are bone health, heart health, cellular health, then this is a product with all these different things in it that might appeal to you. And just like every product you ever see me recommend, please know that this is GMP certified, it's made in USA facilities, and it's third-party tested for purity and potency. So if you want to give your cells, your heart, and even your bones proactive support, click on the link below and grab 4Well's resveratrol complex. Use the code Dr. Doug 4Well, it's the number 4Well, W-E-L-L, at checkout, and you'll save 10%.
All right, so I'm going to talk about our clinical strategies when it comes to the bone health drugs. And remember that we really don't use bone health drugs very often. It is rare that we actually recommend prescribing a bone health drug. We are generally going to go through a comprehensive approach that does not include pharmaceuticals, except for hormone replacement therapy. But let's talk about each of these drugs as we go so that when we talk about how we do them in a comprehensive way, they'll all make sense. So let's talk about the bisphosphonates. So bisphosphonate drugs, you've heard of these. They're things like Fosamax, alendronate, Actonel, Boniva, Reclast. So a lot of these drugs that you hear advertisements for when it comes to bone health. This group of drugs is in the class that I would call anti-resorptives. So they essentially stop osteoclasts from working. They essentially slow down bone resorption, right? And if you look at the literature, you can see that it does increase bone mineral density. So there is a 5 to 8% increase, according to the literature, in bone mineral density in the spine and about 2 to 4% in the hip. And it does reduce fracture risk in these studies. So this is why they're popular with traditional doctors, because they achieve the goals that the doctor is looking for, which is to reduce the immediate fracture risk. So it's not wrong to use these drugs, but let's talk about some of the potential risks. So number one is if you're taking an oral form, there is a lot of potential GI issues. So nausea, esophagitis, which is inflammation, irritation of the esophagus. Some people get really bad GERD. There's some other potential scary things that it might be associated with in the GI tract, but not as well studied. The two things that I talk about most frequently, though, are osteonecrosis of the jaw and atypical femur fracture. So those are two things that occur because of dysfunctional metabolism of bone. You've probably heard me talk about the fact that osteoporosis is a dysfunction of the metabolism of bone with too much breakdown, not enough buildup, right? So you're kind of imbalanced. Well, these drugs kind of make it worse. Now, they do work in the short term, but the problem is that bisphosphonates literally poison osteoclasts. So they just basically stop working. And we measure bone turnover, so we know when somebody comes in on these drugs, we can see that their CTX, the breakdown marker, is extremely low. But as a result, so is their P1 and P. So let me get back to this osteonecrosis of the jaw and atypical femur fracture. These are two really devastating things. So osteonecrosis of the jaw is just what it sounds like. Your jaw bone literally dying and rotting. You can't heal your dental work. If you have to have an implant, if you have to have a root canal, bad things can happen because the jaw bone has a really high turnover rate because of all the stress that we put through our teeth. If you stop that turnover, bad things can happen. And I think this is really underreported from a frequency perspective because when I talk to dentists, they see it all the time. But when you look in our studies in the orthopedic literature, it doesn't seem to happen that commonly. So I think because we're crossing over into a different area of medicine, I think that there is an underreporting of osteonecrosis of the jaw. Now, atypical femur fracture is something that I did see when I was in practice. It's something that I did have to fix. And I can tell you that it's hard. An atypical femur fracture is a fracture of the femur, the thigh bone, that occurs in a place where it probably wouldn't occur under the mechanism in which it's occurring. It occurs because the metabolism of the bone is dysfunctional, and as a result, the bone gets more dense, but it gets more brittle. So then it breaks in a different area because of the stresses on the bone, and they can be really hard to fix. Not only are they hard to fix, but they're also really hard to get to heal because there is just no bone turnover. Imagine if you were to try to build a new highway. Let's say we're redoing a city, we're building a new highway, and you just tried to put an old highway on top of a new highway. We know that that's not going to work very well, right? That highway is going to fall apart. From a bone perspective, it's kind of the same thing, where we say we need the osteoclast to break down the bone in order for the osteoblast to build the bone. And like I said, we are measuring bone turnover markers, so we see that when you reduce CTX with a bisphosphonate, you reduce P1 and P. That's why you see bone mineral density increase initially, but eventually it will plateau, and the risk for osteonecrosis of the jaw and atypical femur fracture will start to increase around the 3 to 5 year mark. So is there a time and a place for bisphosphonates? Yes. I'll get to that at the end. All right, so what about Prolia? So Prolia is a drug that is actually really popular right now because it is an every 6-month injection. So doctors like to use it because they know their patients don't have to worry about taking a pill. It's convenient. Prolia is kind of a cool new class of drug. It's called a monoclonal antibody. So it's actually using your immune system to target this thing called rank ligand. Now, this is a really cool mechanism, but functionally, it actually still works similar to a bisphosphonate. It actually slows down the formation and the survival, shortens the survival rather, of osteoclasts. So it is going to, again, reduce bone resorption. It will increase bone density, but again, at the cost of shutting down the osteoclasts. So we see that same thing where P1 and P osteoblast function also drops. If you look in the literature, you do see, again, an increase in bone mineral density in the spine by now 8 to 9%. So this is better than bisphosphonates. In the hip, 4 to 6%. This is over the course of 3 years. So again, it's a really popular drug because it is something that you can take for longer than 3 to 5 years. We have safety data out to 10 years, and there are people that have been on it for longer than that. The challenge here is that we still start to see the same osteonecrosis of the jaw and atypical femur fracture because you are shutting down bone turnover. Prolia, though, it takes a little bit longer to occur than it would in a bisphosphonate because it's not quite as effective at poisoning osteoclasts. So you do see a little bit better safety in the long term, but again, it's still not long term because you have this sort of 10-year window, maybe a little bit longer, depending on what you want to do from a risk perspective. Now, another interesting risk here with Prolia is that because the rank ligand is part of the immune system, it actually can have an impact on the immune system too. So the osteoclast progenitor cell is also the progenitor cell that becomes a macrophage. A macrophage is part of the immune system, and it's really important to go around and gobble up pathogens and bacteria, and it's a really critical part. So you actually see some signal, it's not that common, but you see some signal of increased risk of infection for people that are on Prolia. So add that to the ONJ and the atypical femur fractures. Is this something that I would jump on as my only tool for bone health? Absolutely not. I still think we need a comprehensive approach. Is it appropriate for some people? Yeah, I'm sure that it is. I personally have never prescribed it because we're looking at a different way to improve bone over the long term. The other additional risk that does pop up that I just wanted to mention, it just popped into my head, is there is some concern around this thing called rebound bone loss or rebound fracture risk. And that comes from some studies that looked at the safety data after 10 years. And what they found is that people, when they came off of Prolia, there was an increased risk of vertebral fracture and multiple vertebral fractures. So that's concerning too. I think in general, if someone's going to go on Prolia, probably the thought is that you're probably going to stay on it. Or if you're going to come off of it, you're going to have to, consider other drugs, another pathway. But you probably can't stay on it forever. And if you come off of it, there is some increased risk. So just some challenge around Prolia for me. Again, I'm not prescribing it. I'm not recommending it for patients for the most part. All right, so let's talk about my favorite group when it comes to drugs. And I say that carefully because I still don't prescribe them often. But if I do prescribe a drug, it is in this class. So I look at the anabolic drugs of Forteo, teriparatide, Tymlos, abaloparatide. These two drugs are not going to shut down osteoclast function. In fact, because they work through parathyroid hormone in a pulsatile way, they actually stimulate osteoblasts, so the building cells, and then as a result, osteoclasts start to do more work as well. So we're actually now building bone. We're ramping up bone metabolism. And so you can see with the research that there's an increase in bone mineral density around 10 to 12% in the spine, 3 to 5% in the hip over the course of 18 to 24 months. So generally, in the medical literature, you see that this type of treatment is reserved for patients that are at high risk of fracture. They talk about the potential risks of the drug, and they talk about the cost of the drug, and that is real for sure. The risks of the drug, though, we see this. I've heard of it. Honestly, I think I've only seen it in one patient. But you kind of run the risk of calcium dysfunction. So they talk about hypercalcemia, meaning your blood levels of calcium go up. And it's just because you're mobilizing bone. You're moving calcium around. So you can get symptoms from that, and that's absolutely true. So that should be monitored carefully. But the real risk that people talk about and seem to be fearful of is this risk of osteosarcoma. Let's talk about the osteosarcoma thing real quick. When they did the original animal studies to get into the FDA trials to get the drug approved, they used a rodent model that had a predisposition to develop cancer at high rates. So it's not really surprising that if you give that kind of an animal a drug that rapidly increases bone metabolism, that they would generate a bone tumor. And in fact, they did generate a bone tumor. In fact, it was a bone cancer called osteosarcoma. Also remember, though, that these were young animals because they don't live that long. So if you wanted to be on it for a long time, you got to start young. When we look at osteosarcoma as a disease in humans, yes, it occurs, but it occurs in young humans, which is absolutely sad. And I've taken care of some of these patients in the orthopedic realm, and it is a very challenging diagnosis. But we never see it as a result of this drug in an older population. So I probably wouldn't give this drug to somebody with an open growth plate. But for someone who is skeletally mature, I don't think there really is a risk of osteosarcoma because there's never been a reported case of it. It's not in the literature. I've never seen it. I've never heard of it. So really with these drugs, I'm more concerned about the dizziness, the leg cramps, the hypercalcemia. That's really about it. And that, you can easily ask patients about those and you can get labs and that's fine. Some people don't tolerate it, and that's okay too. Everybody's experience is different. But here's the challenge about these drugs is that initially they were only approved to be used for 2 years. That has been taken away, but insurance companies are generally not going to pay for them for more than 2 years, and they are very expensive. So while this is a tool to consider, we really only use it under certain situations, and I'm going to talk about those in a minute. All right, let's get into this last drug. So the last drug I want to talk about is Evenity. So Evenity is a drug that works by blocking this thing called sclerostin, which is a protein that inhibits bone formation. It works on both sides of the equation just like a natural tool, except that it's not consistent, and I'll talk about that. What's really profound about this drug is if you look at the literature, it says that it increases bone mineral density in the spine by up to 15%. Woo! That's in 12 months too. So that's a lot of bone mineral density increase. The hip, not nearly as good, 4 to 6%, so kind of similar. Prolia and bisphosphonates, not quite as good as that. But again, it's over the course of 12 months. So you see this rapid BMD improvement in the spine. So there's clearly a potential use for it right there. There's a rapid reduction in fracture risk as well. So for people that are actively fracturing, this really could potentially make sense. However, everything comes with a risk. So the risk for this drug is really talked about mostly around cardiovascular health. So there was one of the two studies, the two main studies that were done for the FDA approval. One of them showed an increased risk of cardiovascular events like heart attack and stroke with taking the drug versus the placebo. The other study did not. So there is a recommendation that if anybody has known cardiovascular disease, previous MI, which is a heart attack, I don't know if it's 6 months or 12 months or whatever, but they recommend not to use this drug. There's also other potential side effects like joint pain is more common with this one, headache. But the biggest challenge is that there's only a 12-month window in which you can use this drug. So again, it's a really short window of how long you could potentially be treated with this drug. My experience, and if you look at the literature on this, what really stands out to me is that we kind of consider this to be an anabolic drug, but it's really not. It actually works, like I said, on both sides of the equation. And what's really compelling here is that it is anabolic for the first 6 months, but then it becomes anti-resorptive. When people are looking at this as an anabolic drug, we say, well, actually only for the first 6 months. And then if you want to continue to build bone, we might need to switch to something else, which would be the traditional model, or have another plan in place, which is my model. It's pretty expensive. It's a monthly injection. I don't view it as a long-term solution, but for someone who's actively fracturing, it really could potentially make sense. We'll talk about that at the end. Another group that we could talk about would be this group called Selective Estrogen Receptor Modulators, or SERMs. So this would be drugs like raloxifene, Avista in the United States. There's other forms in other countries. So raloxifene is an interesting drug because it mimics estrogen in the body. It acts on some estrogen receptors, but not all. So it does help to maintain bone density. It does reduce the risk of vertebral fracture, but it's not nearly as powerful. So it can increase bone mineral density of the spine by about 2 to 3%. Again, it can protect against vertebral fractures. The biggest potential use here is for those that are at high risk of breast cancer who are not considered to be candidates for estrogen. This can kind of work through that same pathway, and it is actually protective of breast cancer. So there's a potential role there. But like all oral estrogens, there is a concern for an increased risk of blood clot. It also can cause hot flashes because it's mucking with your estrogen receptors, and it really doesn't seem to do much for hip bone mineral density. We have used this drug in the past. We've seen some negative side effects and some concerning things from my perspective, so we actually don't recommend this drug anymore. We are also much more open to using estrogen in areas where some people have told that they're not candidates. So we don't really need this drug anymore. And again, I don't like the potential side effects. So we have stopped considering SERMs altogether. Now, the last drug I want to talk about is calcitonin. So calcitonin is kind of cool because it is a hormone that acts directly on osteoclasts and inhibits their activity, but it doesn't poison them. So it does reduce bone resorption. And I like to think of it, when we were in medical school, we learned that calcitonin tones down the calcium. And so it just slows down bone resorption. And if you look at the literature, it does improve bone mineral density, although modestly, 1 to 2%. The biggest use of this drug, though, is in pain relieving effects of vertebral fracture. So for people that are still having pain from a vertebral fracture, calcitonin can help to stabilize that fracture. It is really an effective tool there. The downside, of course, is that it doesn't have any impact on hip bone mineral density. So that's important for someone who really has hip challenges. There is also this weird association with an increased risk of liver cancer with long-term use. So it's actually been discontinued in some countries. It's really lost popularity as a result of that. Nobody wants liver cancer. It is something that I would consider using, but let me walk you through kind of how we do all of these things, because it all comes together under certain circumstances. So we have all of these potential tools, and I don't think that we should ignore pharmacology. I just think that it's overutilized. So let's walk through how we use these drugs. Before I get there, I just want to make one special comment about hormone replacement therapy. I'm not going to talk about it in full review here. We've got plenty of other videos on that. But just recognize that I do also consider this as a tool for bone health. Estradiol is actually FDA approved for osteoporosis. And if you look at the literature, you see similarly 9-10% improvement in bone mineral density with the right protocols. So BHRT really should be part of this conversation, but I'm going to put it somewhere else for now. We're just going to talk about the other pharmacological approaches and how we use them clinically. All right, so let's talk about the anti-resorptive drugs. So when it comes to bisphosphonates, Prolia, and even Evenity after 6 months, Is there a role for these things? Yes. What I like to tell patients is I don't want to use these unless I know the time frame in which we're going to use them in, or there's no other choice. So for example, an 85-year-old who is lost their independence, can't do resistance training, doesn't really have a lot of authority over their eating. We want to slow down their bone loss. Yeah, Prolia might make sense, right? Bisphosphonate might make sense. I think another really good example would be for a younger patient, let's say a woman who has had a diagnosis of breast cancer who chooses to go through a traditional therapy, potentially anti-estrogen therapy, aromatase inhibitor. That's an example where, especially a woman who was premenopausal or even perimenopausal, when she goes on that therapy, her bone mineral density is going to drop like a rock. So going on a drug that's going to slow down that bone loss for a defined period of time, you're on an AI for 3 years or whatever, that's a pretty reasonable approach then, because you know how long you're going to be on that drug. And if you come off that drug and you are at a much better starting point with your bone, it's a much better place to start a bone health journey than it is to lose bone dramatically for 3 years, lose 15% of your bone mineral density, and then try to claw your way out of that deep dark hole. So that's another area where, yeah, maybe that might make sense. All right, so what about the anabolics? Well, like I said, this is my preferred choice of drugs, and we do use it when somebody is starting in a deep dark hole. If they have high fracture risk, have had multiple fractures, low T-scores. So I'm okay with using them. It amplifies what we do. But my goal is not to use them and then have to jump to a bisphosphonate or Prolia. My goal is to use them and then have a very comprehensive plan set up so that we can then have them discontinue that drug and then watch them over time. And we are successful with that. It's actually pretty easy to do. You just have to have a plan in place and then make sure that you keep checking to make sure that you're doing fine. Evenity, I mentioned this a little bit, where this is a great drug for people that are actively fracturing. So if someone is having multiple vertebral fractures, this drug will help stop those vertebral fractures and help them to get on the path to healing. But I really only like it for about 6 months. So this is a really short time window. It's good for somebody who is in a really bad starting point, but we really need a long-term plan. Calcitonin, again, we're using it for people that have pain from fracture. That's about it. We're not using it in the long term because of the concern for any kind of a liver cancer. Raloxifene SERMs we're not using anymore. So the big picture with the drugs is that I just mentioned all of them, and except for Prolia, they all have a pretty short window of a time frame in which you can use them. And even Prolia, we really don't know what that time frame is, and we know that once you come off the drug, you start to lose bone rapidly unless you have created a comprehensive plan. So that's why when I look at this, I say, okay, no matter if we're using drugs or not, we need to create this comprehensive plan through the lens of Healthspan so that we could potentially use these tools, these pharmaceutical tools, for people that really need them. But ultimately, they're just an adjunct to what we're already doing. If you look in the traditional medical model, so many doctors are leaning on these drugs because it's what they have time to do, and it does achieve the goal in the short term of increasing BMD and reducing fracture risk. So I don't fault them for that. However, it is so critical from my perspective to create that comprehensive plan so that you can use the drug if you need it, or even potentially not if you are in a better starting point, but continuing to monitor your bone health so that you know that you're continuing to improve bone or at least not losing bone over time. All right, I think I've talked about drugs enough. So if you made it to the end of this video, congratulations. I just wanted to review these drugs because we get so many questions on the drugs because most doctors are recommending the drugs and people are rightfully fearful. So I hope you found this helpful. Again, if you're looking for assistance from a community, consider Healthspan Nation, link in the description below. And also remember that a diagnosis of osteoporosis is not the end, but deciding to reverse it is a beginning. I'll see you in the next video.